Welcome everyone to this Vulval Pain Society social media live research special. Thank you for joining us. I'm Sheren Gaulbert, Vulval Pain Society trustee, therapist and pain science educator. Please say hi in the comments if you're watching live. If you see me looking around, that's because I am looking around for comments. So do say hi if you're watching live and you can see us. We have Kay Thomas in the background from the VPS on Facebook. And if you're watching the replay, of course, you can comment too. Oh, brilliant. I can see people saying hi. Great. Thank you for joining us. As we know, vulval pain is pretty common. We're talking about at least 1 in 7 women in their lifetime. And yet there is a lack of research in this area. So I am really pleased and pretty excited to introduce today's guest, Claudia Chisari, PhD researcher in Vulvodynia. Hello.
Hi.
Hi. Thank you for joining us. Right, let me check. Last time when I was saying that you were going to be on today, I made a real mess of your surname. It's Claudia Chisari. Is that right?
Yes. Yes. Perfect.
Fabulous. Okay, brilliant. Very important. Claudia, you're a researcher in Vulvodynia at the Institute of Psychiatry, Psychology and Neuroscience, King's College London. Before you share a little bit more about your exciting work there, could you tell us a little bit about how you came to focus on Vulvodynia in this particular area?
All right. So I did my MSc in health psychology, still at King's College London, a few years back, and I started looking at. We were studying a lot of chronic pain, and I was quite fascinated by pelvic and genital pain in general because, based on the literature that there was barely anything, and it was quite neglected and under-researched, and I was interested in general in chronic pain, but I could see that there was a difference between female pain, like there was a gender context to women's health and women's pain. And so that's how I started researching the literature a little bit more and found out about vulvodynia. That's not definitely not it's quite a popular, unfortunately, condition. And I found out it was very under-researched though.
Yeah, absolutely. And today, as we go through, those of you watching live, if you have questions about Claudia's research or anything that you hear, just pop those questions or comments in that box. So, Claudia, shall we start off, before you dive into the research itself? We hear about the biopsychosocial model, the BPS model. Tell us a little bit more about it and what it looks like in Vulvodynia.
So, well, in theory, there's no. The reason I started my PhD is because there wasn't such a thing. So the conceptualization of vulvodynia, the way vulvodynia is acknowledged and recognized, is very dualistic. It's either biomedical, so there's a bit biomedical understanding of vulvodynia, and then there's no sort of inclusion of psychological and social factors in the experience of vulvodynia, in the impact of vulvodynia. And also sometimes there's the other way around, doesn't really take into consideration the physical symptoms of vulvodynia. There wasn't something that acknowledged both, really, and not that was evidence-based anyways. And so there, we have to have a shift from a purely biomedical concept of vulvodynia from any illness, really, because of course, if you live with a long-term condition and one such as vulvodynia, where there's so many problems with the diagnosis and treatment, and it has such an interpersonal impact in addition to the physical impact that you may have, then you have to acknowledge the role of psychological factors. That's not to say that there's no medical condition, of course not, but that living with a long-term condition that's physical has a psychological impact as well, which is normal.
Yeah, absolutely. And in terms of, you talk about psychosocial approaches and that perhaps the evidence didn't exist prior to this. And in the wider context of persistent pain, what I suppose people might know as chronic pain, we're trying to move away from that and maybe call it persistent pain, because chronic just sounds, well, it sounds awful, doesn't it? It sounds like it's forever, sounds like it's something chronic, we might say, in Britain. But it's not ideal. So persistent makes it sound like there is an end in sight. It's something that's persistent, or maybe persisting sounds like there's a way out. So tell us a little bit about psychosocial approaches in persistent or persisting pain.
So at the beginning of conceptualizing pain, it was similar to Vulvodynia. There was a big sort of focus on biomedical factors and no space for psychological factors interacting with disease-related factors. But then over the years, especially around the CBT time, so in the 60s and 70s and 80s, there was a much bigger shift to understanding pain as an experience that also has psychological and social factors embedded in it, in addition to the physical symptoms. And so there's a success story, the success story of CBT, which helps with the pain, and it can be used as something that can help with the distress of the chronic pain, which is something I'm sure is an experience that's common for women with Vulvodynia, but any other type of persistent pain condition would be the same. So it helps a lot more on the impact of pain and on the distress of pain rather than the pain severity itself. However, it does also help with the pain. And we know that CBT has worked, but now we're at the stage where we want to embrace things that maybe working a little bit more, maybe a bit more efficient, and also making something that's a bit more tailored and individualized. So the experience of living with Vulvodynia for a woman may be different from someone living with low back pain. And this is why we try to have an understanding of psychosocial factors around Vulvodynia first, to have a picture of what it means to live with Vulvodynia, to then guide treatment development in pain that is based on acceptance and commitment therapy. So these acceptance and commitment therapy belongs to the third wave CBT approaches that are the latest sort of approaches that are used for pain, and they have strong research support.
Okay. Before we get into ACT itself, the psychosocial factors, what do they look like in Vulvodynia then?
So this was the first step of my PhD. It was to research, have an understanding of what's around, what's the literature. And so a systematic review was a way to have a big picture, or a bigger picture, to what the challenges are, what the psychosocial factors are. And unfortunately, the situation is that much of the psychosocial research is focused in provoked Vulvodynia. So of forms of Vulvodynia that are provoked by touch or intercourse, mixed and spontaneous, there isn't much. And so that meant that my conceptualization of Vulvodynia was only on provoked, because there wasn't much else. But anyways, what I found is that first of all, psychosocial factors are related to symptoms of pain and pain impact and sexual functioning and sexual satisfaction. So we decided to also embrace the sexual impact that Vulvodynia may have. And we found that psychosocial factors are related to this. There is an association, but also which ones. So we found that there are differences to other pain conditions based on the psychosocial factors we found, so there are similarities in psychosocial factors and there are differences. We found a range of factors that are similar to other chronic pain, other persistent pain conditions. And for example, these are depression, anxiety, perceived injustice. For example, the unfairness of the pain, no one understands my pain. And also other pain-specific factors, so catastrophizing, pain fear, and hypervigilance, and low pain acceptance. So these are shared with other pain conditions that we know of. However, we also found that there were unique factors in Vulvodynia, and that can help us with treatment development. And these were, because it's PVD, a lot of them were revolved around sex. So engagement or avoidant factors that are around intimacy or sex. And so we found a lot of factors that promote engagement in intimacy or sex and factors that promote avoidance in intimacy and sex. Body exposure anxiety during intercourse. So the idea of covering ourselves as we have sex, in other factors like attitudes to genitalia, body esteem, and interpersonally oriented factors that are avoidant in nature are related to more pain, whereas other factors that are positive, as in they have a positive effect with regards to pain, they lower the pain, they're related to lower pain, are, for example, self-efficacy. So the idea that you can, I can do this, the pain, I can manage, it's bearable, or sexual communication motivation, or having sexual goals that are approach-based and not avoidance-based, and sexual communication. So we do have a lot of interpersonal factors in vulvodynia that I think are bigger than we thought they were.
Okay. And you're right, because we do see this in other forms of persistent pain, and the fact that this hasn't been explored in any kind of depth until perhaps now, until you've come along and decided to do this work, is astounding, isn't it? Considering so many experience this at some point in their lifetime. But it's interesting you say there are some specifics when it comes to provoked vulvodynia. Just to touch and dive into this a little bit more, the body exposure anxiety during sex and that kind of self-esteem. And, we will go into far more detail in this in subsequent live streams as well. But just to touch on those, what did you find there?
So I found, and it's something, body exposure is something that then I looked at in other two subsequent studies that I can actually tell you a little bit about. So body exposure anxiety was one of the biggest factors that I highlighted in this study as a potential important treatment target. And it was only researched once, so it has to be researched again. And again, it may be only relevant for women who have provoked pain rather than other, mixed or spontaneous types of vulvodynia. But it's the idea that when you do have intercourse, you try to hide parts of your body. So it's called body exposure anxiety and avoidance during intercourse. So you do have intercourse, but it's how you have intercourse. So trying to hide your body, having clothes on, or being self-conscious about your body during intercourse. I mean, these are things that as women, we've experienced to some degree. But when you have genital pain, many people focus on the pain avoidance, but there could be other types of avoidance in place, like body avoidance rather than pain avoidance. And this is, for example, something that we found and we researched in the other two studies that we did before the intervention.
And how about cause and effect? Are you saying that, women, who have this kind of body exposure anxiety are more likely to develop provoked vulvodynia, or the other way around, or do we just not know?
I would say neither. So what we found in this study was in this, review where I looked at studies that looked at body exposure, is that body exposure was related to higher pain. So the more you try, the more you have this factor, the more you are having pain. And it's probably because I'm just thinking here, but it's probably because if you are focusing on your body rather than the sexual experience, right, there's a whole lot of attention and cognitive factors in place that don't allow you to feel pleasure, but they might be targeted towards more negative experiences, which in turn make you feel more pain, maybe. Or it's the other way around. You have this pain all the time, and then you become a bit self-conscious about you, and it could be about your body as well. So we don't really know the direction of this association, but we know it's present in women with provoked pain. And we've looked at this factor in women with mixed and spontaneous pain, and it is still there, but to a much lesser degree. So yeah, we looked at a range of psychosocial factors, among which was body exposure anxiety, and it seemed to be a less important factor there. And my guess, it would be that I think sex-related factors in women who have pain every day on so many aspects of life might be less relevant, because they may have issues with walking, sleeping. And so sex-related factors may be less significant there, or they may just sort of be in sort of happening with other things at the same times, with other challenges.
Yeah, one of a number of things. Yeah,
sure. Potentially.
And you mentioned self-efficacy, sexual communication and goals. Can we talk a little bit more about that? So when you're talking about self-efficacy, what do you mean?
So pain self-efficacy is the idea of, I believe I can cope with this pain. So self-efficacy in general means I can do this. Like, I believe in myself in succeeding in this thing that I'm doing. Pain self-efficacy is I can take the pain. The pain will be bearable. And so having this sort of being higher in self-efficacy, so believing that the pain is, that you can deal with the pain, is related to lower pain and higher sexual functioning. But we don't know if maybe having less pain makes you think that you can deal with it, or thinking that you can deal with the pain more might lead to lesser pain. It's probably, these relationships are very they're interconnected, so it's hard to say that one caused the other. I don't think it's neither, to be honest.
It's complex, isn't it?
Very, very complex. Yeah.
We like to think, wouldn't it be easy if we just said this is the thing that causes this? It's just not linear like that. We are complex beings. You mentioned sexual communication and goals.
Yeah.
What do you mean?
So sexual communication is the way you communicate during sexual relationships, and also outside of the bedroom. And to my interest, I found that that having better sexual communication with your partner around, sex, things like what your preferences are, if you have pain, in what context you would prefer to have sex, is related to lower pain. It could be that there is a form of adjustment there in place, because there's more communication around sex. There's less anxiety, maybe because you've talked about what you want from sex. Or it could be because you have less pain, you're more inclined to talk about it because you're less distressed by the pain. Again, very hard. But in general, what we found through this review is that there's a lot of interpersonal factors. We talk a lot in psychology about biopsychosocial factors, and we focus a lot on the psychological factors, not a lot on the social factors. And yet with this review, I found such a big side of interpersonal, as in social factors, that sort of have a place within the pain experience of vulvodynia.
Yeah. Okay. And when we talk about social factors, I suppose that means with someone's partner, but also the wider society, right? We're talking vulval pain here that people may not want to talk about openly, and there may be potentially shame and other emotions wrapped up in all of that, because as a society we just don't seem to talk about these things, however prevalent it is, because it is prevalent. So in terms of particular approaches, you mentioned acceptance and commitment therapy. Did you want to talk a little bit more about that, or the social side of things in the biopsychosocial model? Throwing it out to you.
So we can, I guess, sort of finish on the social side of things, and I'll add a little bit about that and then dive into the ACT part. You're right about the social part, and it's not only interpersonal relationships, as in like partners. And as I said, this review was focused on women with PVD, provoked vestibulodynia. So a lot of the focus was on sex-related factors. However, my understanding is that there's a lot of women who have they can't walk because of the pain. So there's a lot more to just focusing on intercourse, in understanding how vulvodynia feels like on a daily basis. And so, yeah, there's a bigger social side that's in addition to the interpersonal sort of relationship side of things. One of the factors that we found as quite high is perceived injustice. So perceived injustice is the idea of unfairness, and this condition is no one understands my condition, which, I'm not entirely surprised about that, given the invalidation that women with vulvodynia experience and difficulty in getting a diagnosis or being believed in their pain. There's a lot of injustice around the condition. And it's and by what we found, is higher than other people living with persistent pain. And so here, why is that? Is it because we still have so many issues around, validating women's pain? I don't know, but it seems like it's very high. And I thought that was quite interesting. And it highlights the gendered context and social side of vulvodynia, because it's no one understands my condition. So people around me don't understand it. So yeah, you're right about the social side.
And I'm just kind of looking in the comments and kind of people writing just about kind of what you're saying and their own kind of experiences. People talking about going to see a psychosexual counsellor. Again, we will dive more into that in future live streams, so stay with us, more on that soon. So let's talk acceptance and commitment therapy. You say it's kind of the third wave CBT intervention. Is it an intervention? How would you describe it?
I would describe it as a treatment approach.
Yeah.
I think it's a bit more it's not very harsh. It's a bit nicer that way. And it's a way of approaching persistent pain. It's been there for a while and it has strong research support. However, no one has really looked at it in vulvodynia. And so the idea is CBT, traditional CBT, and I'm making it very simplistic and a bit stereotypical here, is that you have certain thoughts that may be adaptive or maladaptive. So I don't know, things that might be wrong or right. So there's a bit of a judgment quality to it. However, ACT is based on accepting the thoughts as what they are, how they are, and acting towards what's important to you, regardless of what these thoughts are. So it doesn't matter what I'm thinking. It's not the content that it's important. It's more like, where do these thoughts lead me to behave in a way that's important to me, or do they not? Because if they don't, then I shouldn't listen to them, and I should focus my attention on what's important for me. So it's all about engagement in valued life activities, rather than fixating a lot on whether the thoughts are right or wrong. Sometimes thoughts are thoughts, and it's normal. We have negative thoughts, we have positive thoughts, and when we live with an illness, we may have quite horrible thoughts, and that's okay. It's about normalizing these thoughts, but managing to do things that are important to us. So that's what ACT does. And a little bit about ACT is that it's been done in, one of the processes of ACT is present moment awareness or mindfulness. And we know that mindfulness has been, they've done some studies of mindfulness in women with sexual pain, and including vulvodynia, but provoked vulvodynia. And it actually, being in the present moment, focusing on our sensations, physical and mental sensations, helped with the pain. And so we know that worked, but we also need something that's a bit more theoretically driven, because ACT has a model that it's based on, and it's called psychological flexibility model. And also, we want to focus on the valued goals activities. In addition to being present moment, we want to redirect the person to what's important for them. And so it's a bit more complex than mindfulness. And in such a way, it may tackle more issues, more difficulties. And so we've done that, and we've tested whether psychological flexibility model, which is the model underlying ACT, we've tested it in Vulvodynia to see, does this model apply to Vulvodynia? Because if it doesn't, there's no point in even trying to test an ACT intervention. And we did 2 studies, and it did. All the facets of psychological flexibility, we tested 3, the main ones, and they were all related to the symptoms of Vulvodynia. So we looked at pain impact, emotional distress, because, okay, it's not an official symptom of Vulvodynia, but you are probably going to have some degree of emotional distress, and sexual functioning and satisfaction. And to some extent, the model on the whole applied to Vulvodynia. And so we did the treatment after that.
Okay. So what did your research show? Don't keep us waiting.
So what we did was we did a digital intervention. So we did an ACT-based intervention, and I also created a manual based on all the findings that we had throughout the years to sort of to add to the digital component that's an ACT-based intervention. So I sent this manual that had some Vulvodynia specific information, things like perceived injustice, the interpersonal stuff that we talked about. And we looked at women's levels of pain, distress, and sexual functioning every day before the intervention. So we gave an app where they could do this daily diary before intervention for a number of days to see how they're doing before and after, and during, sorry. And so to see if the start of the intervention corresponded with a drop of pain interference, and if the sexual dysfunction got better and the emotional functioning got better, and it did. So it didn't for all the factors. So for pain impact, pain severity, and sexual functioning, there was a significant improvement with the intervention in introducing the intervention. So we had a drop of, like, for example, in pain severity, pain interference of 3. So from 7 lower, it was on average, it went lower by 3 degrees. So it was quite substantial. So a clinically significant improvement in these 3 outcomes.
And did you say this was a digital intervention?
Yeah.
Okay.
This was for many reasons. So it was because of COVID, but we had already decided to do a digital intervention, to be honest, and we thought it might reach more women, and it's just easier to implement. So we wanted to see, does this work? So they were logging in on a portal where there were twice a week for 3 or 4 weeks, and then once a week for the other 2 weeks. So it was 6 to 7 weeks, the intervention. And there were pre-recorded videos on ACT, and there were exercises to do. So ACT is very practical based. So these pre-recorded videos talked about metaphors, and you needed then to try that, and you need to try these exercises at home whenever you wanted. I mean, you were already at home, but whenever you please, to just continue improving on that skill. And the manual that I was sending as well, I was sending chapters along the line, and that's how it was. It was quite easy because you could basically log in whenever you wanted and share your experience with a therapist, which would be me. So women were then, after the session, sending their thoughts on that session to me, and I would reply to them. So there was a level of engagement. It wasn't just pre-recorded videos.
We've got a couple of people who are, would your research be available to read? Someone else has asked, will we be able to see the digital interventions, exactly what we're needing to achieve within each profession dealing with these patients? So how close are we to reading this?
I mean, I've analyzed the data now, which is hopeful, which is to see, did the intervention work or did it not? And so what I will be doing is I will submit the research to a journal, and I'm hoping to do that within the next 1 to 2 months. I would say 2 months maximum. That's where where it would happen, and then it would be published, hopefully at some point. So it shouldn't be too long. I can't give an exact timeline, but it is in the process of being submitted and then, of course, published. Yeah.
It's really exciting, isn't it? Because, what would you say are the possibilities that are opening up with this?
So this is the first study of ACT in Vulvodynia that's ever been done, and I'm very happy that it worked. I thought it would work to an extent, but I didn't think it would work so much. And this gives me hope that, ACT could be implemented, could be, something that's available to women, and it would just help with the many symptoms that, they may live with because of the Vulvodynia. So I think in general, the hope is that this would translate into implementation, and also knowledge, I guess, if you're living with Vulvodynia, knowing that potentially ACT can work for you, then seek ACT, and, or in general, psychological therapies can have some effect on the, on the management of pain of Vulvodynia, and mindfulness as well has some quite good evidence. So in general, I think it's just spreading the word, and implementation would be the ultimate goal, which is great.
You're right. We're not saying to people that this is a standalone. When we're talking biopsychosocial, really, again, we're going back to these multidisciplinary teams, getting away from the biomedical model of, I'm hurting here, that must mean there's damage. We know that there isn't that kind of relationship between, something we might see on the surface, whether we can see it or not, and the intensity of the pain experience, that there isn't that link there. So, this will sit within that larger multidisciplinary framework, wouldn't it?
Absolutely, yes.
Yeah.
And and also it's one body, right? You can't really say this is psychological, this is medical. It's all the same. So it's acknowledging that when there's some pain experience, there's some psychological experience, which then feeds into the pain experience. We're not, separated as and that means that treatment needs to be multidisciplinary. Absolutely.
Yeah. I don't know, again, it's just, we can't have just one approach that works. As Claudia says, we can't divide ourselves up into, this is the biological component and here's a psychological component, maybe there's a social component. These are absolutely intertwined and interlinked. And for anyone watching, there is a webinar that we did last year on the biology of pain, kind of simplified down, and we'll put up a link to that at the end, and we'll put it on social media too, so you can go in and dive a bit deeper into those different components to get that wider understanding. So what's next then, Claudia, after this?
What's next? I think scaling that up. So what we've done with the ACT intervention is that we've to give space to the individual rather than group averages on intervention effect. So that means that there's a big when you try a new intervention or a new treatment, you do these big studies, RCTs, which are randomized control trials. So you have 400 people, and then there's a control group where there's no intervention and the group where there is the intervention, and you compare them. Did they improve? Did they not improve? And you look at the group average. So did they improve on average? Now that's all good and well, but it doesn't really tell us anything about the individual. Does it work? Mm-hmm. If yes, for whom? Why? Mm-hmm. And I think going back to the more idiographic, which means around the person, centered around the person, is a better approach. So what we did was we looked at each person's trajectory over time. And that meant we didn't have a lot of people, but we know what happened to each person. to a bigger extent than, it would have happened if we had like 300 people and we could only get 2-3 time points of their, trajectory. And so we have data, we have looked at the intervention effect of 8 people. Now, that's not a lot, but each of them significantly improved on at least one of these outcomes, so pain or sexual functioning or emotional distress. And so I guess the bigger step now is, does it work with more people? So does it work on a bigger group? So I think scaling this up would be great. Yeah.
All right. Yes. So yeah, I would be very interested to see if this could be applied to patients with mixed or unprovoked pain as well as vestibulodynia sufferers. I suppose that too is something to be looked at, isn't it?
So we did do that. So our intervention was with people with provoked and mixed and spontaneous subtype. So all of my research, I think that was the question, right? If it worked. Yeah. So all of my research, because of what I found on this first study that was only on provoked, all my research was looking at subtypes and including of all types of vulvodynia, especially mixed and subtype. There's really nothing there. So all the intervention, all the studies we've done are with everyone. Doesn't matter what type. Yeah.
Okay, good. All right. So I wonder, I'm just looking through the comments, and please do feel free to post a question or any comments that you have on whatever you've heard. I'm just quickly trying to read through. Okay. And remember, to those of you who are watching, whether you're watching live or on the replay, that we've had a number of live streams already. We've covered physio, dermatology, a number of different areas, and they are all on our Facebook page and also on our YouTube channel as well. So do have a look at those. And we've got 9 expert webinars from last year as well, when we first went into lockdown. So there's a comment here. I'm sure there are lots of women watching that will be happy to take part in a bigger trial. Right. How do you recruit for these trials?
How you get these trials? With funding, mostly, which is the harder bit. Yeah.
I mean, how could, if someone wanted to get involved in a trial, someone with vulvodynia, is it as easy as getting in touch with someone and saying, I want to be involved in a trial? How do you recruit women onto a trial?
So it depends on the mode of recruitment. So if it's NHS, then you have to go through NHS ethics, get the ethical approval, and then you approach someone with vulvodynia, where you got the approval, and then they may decide whether they want to take part or not. In my case, I did get the NHS approval because I wanted to do mixed NHS and non-NHS, and then COVID happened, and so I couldn't, of course, recruit within the hospitals in March of last year. So, yeah. But in general, that's fairly easy. What happens? I mean, what I've done, for example, is I've posted on Twitter, social media, and the King's research portal that about my research. And so anyone who was looking out for that could get in touch with me. They could email me, and I would what I've done is I've talked to them over the phone or by email and told them, this is, the information of the research, the information sheet, this is the consent form. If you're eligible, then of course take part. So it's not, I wouldn't say it's very hard, unless there are harsh eligibility criteria, which for example, I didn't really have, because I didn't have any age restrictions, because again, a lot of the research in vulvodynia is 18 to 25 or, a premenopausal, but anyone can get vulvodynia. So there wasn't an age restriction. There wasn't a type of vulvodynia restriction. So as long as you have a diagnosis, which I know is hard, but as long as you have it, then you would be eligible, I think.
Yeah. And so Claudia, you're on Twitter, so people can follow you there. Is it at Claudia Chisari? No, it's not, is it? Is there an underscore in there somewhere? It is.
I don't think so.
Look it up yourself. Anyone who follows us, the Vulval Pain Society, on Twitter or Facebook, once Claudia has her results published, we'll be putting it up. We'll be putting it on the website as well. Any future studies coming up, we will also be promoting as well. So, you know, whether you're following Claudia or following us, the Vulval Pain Society, you are going to hear about upcoming studies. And once this is published, and I know that people are keen to read the results.
I mean, I can already tell you that it worked.
Yeah.
You know, so.
Yeah. For those people who want to see the data.
I know.
Won't mention anyone who's looking very, very excited. So any final thoughts to wrap up then, about what you found, about any of this really, Claudia?
So, well, what I found is that there's so much need for research in vulvodynia. I mean, I know it's an obvious thing, but everyone says it and no one really does it. I mean, there's no big vulvodynia research groups in England, which is a shame. And even when I did this big study where I looked at all the research that was done in the past, all the research was done in North America. We don't really have, you know, an understanding of what's happening outside of there. We have some research being done in Sweden, a little bit in Italy, but not strong research groups. So my hope would be for vulvodynia research to be A, interdisciplinary, B, that it looks at improving, you know, psychological treatments alongside biomedical treatments in vulvodynia, and that, you know, it's centered around what women need and want. So a lot of it has to be centered around the impact and what's important for them. Yeah. So my hope is that happens over time. You know, the more you do research, the more opportunities there are to continue and do that research. And so, yeah, that would be my hope. But I hope that happens very soon. I mean, this was a little bit of a drop in, you know, an ocean of potential vulvodynia research to do, which I'd be happy to continue.
Look, thank you so much for the research that, you know, you've already done. And I'm wondering, you know, we can't just leave it all up to you, Claudia. As much as you're amazing, what do you think we need to do to encourage more research into vulvodynia?
I mean, public, I would say, I mean, funding, right? But then in practice, I would say just awareness. I think that if there's a general pressure from the public around vulvodynia, you know, then from women, that would massively be helpful. I know we shouldn't be in a position where we should ask for funding, we should ask for research, we should, you know, say, okay, this needs to be done. But the reality of it is that there isn't enough. And so the more there is, you know, public pressure to, and public sort of, and the more we talk about vulvodynia in whatever form, academic, non-academic, just any form of engagement around vulvodynia is a massive help for all of those who are, you know, don't know what's going on in their symptoms. Younger, you know, we have a lot of girls who have vulvodynia, and we don't really know how they can know about vulvodynia if no one talks about it. So I think just generally sharing and doing research will help then with awareness and more research over time. I don't know if you agree with me.
Absolutely. And we're involved in a rather exciting project at the moment. It is a 2-year project on, we'll reveal a little bit more on vulvodynia in adolescence. So we will reveal a little bit more about that in the coming months in a live stream. Dr. Winston DeMello, who is also a trustee of the Vulval Pain Society, is involved in that. We also have, and I've got to announce this actually, a new member of the Vulval Pain Society team. And we'll put it up on Twitter as well. And people will remember her from coming on before. Before I reveal who that is, any last words from you, Claudia?
No, sorry, I thought it was a question to ask.
No. Let me tell you, so we had Dr. Karen Gibbon on one of our live streams, who is a consultant dermatologist, and she talked about lichen sclerosis, lichenoid inflammation. And so she is the newest member of the Vulval Pain Society team, and we're really happy to welcome her. And so she will be helping Dr. Winston de Mello in this 2-year project that we have underway. We're partway through this. This is a big project on vulvodynia in adolescents, and we know that by what the work that Winston is doing, by going into it and deep diving into it, we really do need to look at this early on, don't we? So that we can prevent it then potentially getting worse. And anyway, we will go into more of those findings later on in a few months' time. Claudia, listen, I want to say a huge thank you for coming on. We have followed your work with bated breath for a while now, and this is really exciting stuff that you've presented here. And in terms of what's coming next, that's scaling up, that's going to be exciting too. And the fact that it works, that's what we want to hear, isn't it? It works. And again, just to reiterate, not a standalone, it's part of a multidisciplinary treatment approach. So yeah, we've got someone saying, thank you. I look forward to reading your findings once published. We know what the findings are.
Spoiled them for you.
It's a thumbs up. So, all right. Next time, following on from today, and I think it follows on quite nicely, our next 2 live streams are going to cover psychosexual therapy and sexology. Our second guest, so we'll start with the second guest in that group. In this, it's quite a wide arching area, as you've mentioned. So our second guest in this area is on the 5th of May. It's Dr. Angela Wright, GP and clinical sexologist, qualified in both sexual medicine and psychosexual therapy. She'll be talking about how the vagina and vulva are affected by menopause. So more on that soon. Our guest next time, 7 p.m, Wednesday, the 21st of April, is Dr. Catherine White, specialist in psychosexual medicine, specialty doctor in integrated sexual health, and she'll be chatting with our trustee, Dr. Winston de Mello, on the Institute of Psychosexual Medicine approach to life. So more on that coming up. We are on Twitter, on Facebook, so do follow us to be kept up to date, and we'll release more details on that upcoming live stream. Healthcare professionals, please do share posts and tweets that can be useful for people. And if you experience vulval pain, we talked about awareness today and building up this awareness. And if you can share our posts, please do, because again, we are talking about something that affects at least 1 in 7 women in their lifetime, at least 1 in 7. So if you know 7 women, then the likelihood is at least one of them is going to be affected at some point. So, please do help us get the word out. These live streams are, of course, free to watch. They are up on our Facebook page. They're on YouTube. So if you follow us there, you'll be notified of when the next one is as well. And as we've mentioned, there's a whole bunch of them already available. So go on ahead and dive in or re-watch, because there is a whole wealth of information there. So, if you are experiencing vulvodynia or any kind of vulval pain, please don't suffer in silence. Don't think that you're alone. There are many women out there, and as Claudia said, there is hope. There are things that work, and the right jigsaw of therapies, that multidisciplinary approach, is the best thing that we have in order to live better with this, or work yourself through it with help, with support. People really do deserve better care and appropriate care at the earliest opportunity. So do help us get the word out there. This has been live stream number 6, and it will be on our YouTube channel. You can rewatch any of the previous 5. There are 9 Ask the Expert webinars from last year there too. So do follow us, connect with us in any of those places. And you can also email us. You could do it the old-fashioned way. info@vulvalpainsociety.org.uk. We hope that you can join us next time for the first of our 2 psychosexual specials. Next time is Dr. Kath White, 7 p.m. BST, Wednesday the 21st of April. That's all from the Vulval Pain Society now. Thank you again, Claudia Chisari.
Thank you for having me and sharing my research.
Yay, it was brilliant. Thank you. And thank you all for watching us live or on the replay. Bye for now, and hope to see you next time. Bye-bye.